Hi, I'm Angie Hagy. I'm the Director of Data and Evaluation with the City of Milwaukee Health Department, and I'm going to talk tonight a little bit about local public health and specifically how local public health works at the City of Milwaukee Health Department. Just to kind of frame our discussion a little bit about myself, I have a master's degree in public health, specifically in environmental health. I got that at the University of Alabama, Birmingham. I started out my career there doing research in HIV. I did some preparedness planning for the state of Alabama. My mom wanted me to come home, live closer at home after her first grandbaby was born, and she got me to apply to work at the City of Milwaukee Health Department, where I've had various different jobs. I started out as an infectious disease epidemiologist. From there, I went on to be the Director of Consumer Environmental Health, which is food inspection. From there, and then I went on to be the Planning and Policy Director. I did a stint as the Director of Disease Control and Environmental Health, and now I'm the Director of Data and Evaluation. So 16 years total at the City of Milwaukee. Basically covering most areas of the department except the maternal child health side. So I've done basically it all. Health. When we're talking about health, what people tend to think about is that clinical picture. They think of the doctor's office, that kind of checkup kind of thing, but health is a lot more than that. The complete picture of health is that mental, social aspect. So really, it's a much more complex thing that needs to happen for somebody to be healthy. So what public health is what we in a community need to do to make sure that everybody's able to achieve health. And what we need to do to achieve health has kind of evolved over time. Public health in its early days focused a lot on infectious disease because that was the biggest need of the time. So we focused on sanitation, we focused on immunizations because those were the major threats to health. But as we kind of got our hands around that, as we created cities that have that type of infrastructure where you have running water, you have septic systems, we have vaccination, we have antibiotics, the need of what public health needed to focus on has changed. The things that now impact our health are changing. So now what determines whether or not you're going to be healthy is not so much, the viruses in our community. It can come down to actually your community. We're learning now that your zip code may matter more than your genetic code, whether or not you're going to be healthy. It's your access to care. It's your housing. Is your housing up to code? Is there lead paint in your housing? Is there mold? Is there green space in your community? Chronic disease is becoming a greater and greater burden on health. So as the things that impact health change, what public health needs to respond to also has changed. When people think about public health, they think about local health departments. But we are just one small player in a much, much larger public health system. Again, we need to impact health on a population scale. When you work in a clinic, you're trying to impact one person. We're trying to impact the community. We cannot do this alone. It is a team sport. So we work with neighborhood organizations. We work with fire departments. We work with police. We work with community-based clinics, labs, elected officials, really anybody who's willing to work with us, we are willing to work with them to try to make population health change. And for that to work, just like any good functioning team, we need certain things to be there. So think about when you've worked on a team, what has to be there for it to work well? You need to have a common goal in mind. You have to find that common ground. So you might not agree on 99% of things, but if you can find that one thing you agree on and work on that, the rest falls into place. You have to have effective communication. You need to be able to share resources towards that goal, and you need to have political backing. And if you can have all of that aligned, you can create collective impact and create the synergy to create tremendous impacts on population health. Now, closing in on the public health system, look at governmental public health. It's a multi-tiered system. We have local public health, state public health, and federal public health. And it kind of shakes out into these buckets. You know, each state has their own health department. Local health departments can be separated out into different systems depending upon where you're located. They can cover a city, they can cover multiple counties, they can cover regions, they can cover territories. It's very variable. And how health departments are at a local level, they can really be just, in some states, the state health department does it all. There are really no local health departments. In some states, the state does part of it. In some places, the local does part of it. In some places, the locals are basically on their own doing their own thing. So here's kind of a map in Wisconsin. We have this thing called home rule. The local health departments are autonomous from the state, but we get direction on certain things from the state. They serve as a pass-through for federal money, but they don't really have a lot of authority to tell us what to do. Now, there's been a lot of attempts to kind of systematically define what is a local public health agency and what they should do. This graph is from the Foundational Public Health Services, and it focuses more on the what. And what you kind of see in local health departments are kind of consistent programs around communicable disease, chronic injury, environmental public health, maternal child health, and usually something around linkage to care or community health access. Another kind of survey that's typically, these are kind of the top 10 services that health departments provide. And this is a survey that's done by NACCHO, and I kind of put up a comparison to what the health department provides. Again, if you're going to be a health department, you usually see communicable disease, you usually see immunizations, you see TB, and you usually see environmental health of some kind. Another way people tend to look at public health is by the core functions and 10 essential services. They kind of more look at and take a public health approach of looking about how we provide our services through assessment, through assurance, and through policy development. And actually right now the DeBeaumont Foundation is actually doing a survey to redefine how public health operates. So you have the ability to fill this survey out, I have to track down the link, and inform how this wheel will change moving forward, because how we operate is changing based on the fact that public health is changing. And why do we do public health? Because at the end of the day, what we're trying to do is we're trying to make people healthier. We're trying to prevent the spread of disease. We're trying to prevent injuries. We're trying to encourage healthier behaviors and encourage access to health services. Now, in Wisconsin, there's a couple of administrative rules that kind of govern health departments. These set the foundations, the minimum standards of what health departments at a bare minimum must do. The DHS 140 is the administrative rules that govern local health departments. And basically it says if you're going to be a health department, you have to do a community health assessment, you have to investigate and control communicable disease, you have to enforce school immunization laws, you have to abate environmental hazards. The companion piece to this is DHS 139, and that basically says, all right, if you're going to provide these services, you need these staff. And these staff have to have these set of minimum qualifications. So as you get more robust, this is what your health officer needs to have. These are their educational requirements. And if you're going to have a nurse in a health department, they need to be at least a bachelor's trained nurse. And if you're going to have sanitarians, you're going to do environmental investigations, they have to be a registered sanitarian. And the directors of these programs, of public health nursing programs and environmental health programs, these are their educational requirements. But beyond that, there is a lot of latitude each local health department has, and how they operate is based on local laws and municipal codes. So now, on to how the City of Milwaukee Health Department operates and how it's organized. We've been around for a very long time. One of the oldest health departments in the nation. We were founded in 1867. We cover just the City of Milwaukee. So there are 19 municipalities in Milwaukee County. I used to know this, like 10 health departments, because they were aggregated based on different municipalities. Waukesha County has one health department, one county. To our north, Waukesha, or Ozaki and Washington, 2 counties, 1 health department. Again, it's totally up to the local jurisdiction about how they want to organize. In the city, we report to the Common Council, and brand new to us, we just got our first Board of Health. Our vision, our health department just went through a reorganization process where we created a new vision, mission, and we went through as a department a complete reorganization. We have a new Commissioner of Health who's been with us now for about a year. Our vision is living our best life, and we're going to get there by advancing the health and equity of Milwaukeeans through science, innovation, and leadership. Our health department, we have our main location, which is downtown right next to City Hall. That's where our administrative offices are. And we also have a public health laboratory located on the 2nd floor in the municipal building. We have 3 satellite clinics. Our Northwest Health Center, which is about 76th and Mill. Our Keenan Health Center, which is about 36th and Hour. And our Southside Health Center, which is about 23rd and Mitchell. The health centers serve as our anchors in the community. This is where our clinics are. This is where we provide our direct services. We do not provide direct services at the municipal building downtown, other than it's a launching point for our staff to go out into the community. Our structure, brand spanking new. We are just in the process of kind of straddling our 2 structures. So this reorganization started a few months ago, and we're about halfway into the process of embracing this new structure. We have 4 branches: medical services, community health, environmental health, policy, innovation, and engagement. And over each branch is a deputy commissioner. And within the branches are divisions, and within divisions are programs. This is a slide actually fresh from our budget discussion last week. We went before Common Council. October is a very contentious time for a local government. By law, that's when you have to settle your budget. And here's just a summary of ours. We have 283 staff authorized. 163 of those come from tax levy or tax supported dollars. Our total tax levy budget is about $14.5 million. To put that into perspective, looking at a 2013 survey of national and local health departments, the 50th percentile budget for health departments is about $28 million. Luckily, tax levy is not our only source of funds. We have a substantial amount of our budget that comes from grants. About half of our budget comes from grants. The issue there is that grants are directed dollars. We don't get to pick what we work on with grants. The grantor does. So if they say it's a grant for working on HIV, you work on HIV. The benefit of tax levy dollars is there are unrestricted dollars. So we get to decide based on community input, community need, what we work on with those dollars. So there's a great amount of more of flexibility. So ideally, we would like to see much more unrestricted dollars, but this is the financial reality to which we live in. Again, just comparing ourselves to the national average, we do kind of line up with health departments of our size. We have about 600,000 which we serve. If you look at the NACHO survey, we kind of come in at 283. In 2013, 269 was the median. I wanted to point out that, again, talking to a group of nurses, that nurses are the backbone of a public health department. If you're in the smallest health department that exists, you're going to have a nurse. If you have one staff member, that staff person is going to be a nurse. Why? Because they're the most flexible person that you have. Because they can give the shots, they can answer the calls, they can do the education. They call on public health nurses to do the clinical, to do the health education, to do the health promotion, to do it all. Now, this is a very proud picture for us. It is our very first inaugural Board of Public Health. And a local Board of Health is not just an advisory committee, it's a governance committee. They're a legally designated body to provide oversight. And you might think, well, why do you need this extra layer? Well, what a health department needs to do might not always be politically a good idea. So having a committee that's there to support you, to say, this is what the science says, is going to be a wonderful thing. They just went for us through orientation and are now coming up to speed with what they need to work on. So we don't have a track record to build upon, but looking at what they do historically or from other health departments, these are the things that they're usually charged with. They decide and develop public health regulations. They help decide policy. They kind of craft your strategic plan. So with policymakers running the show, which is kind of where we've been at for a very long time, it kind of, what your priority is, kind of goes with the political wind. What's in the news, what's driving politics. With a board that is made up with people who have a scientific background, we can come up with now a multi-year plan to address the things that are truly impacting health and pick programs and strategies that are truly going to have a substantial impact on the outcomes. Typically, boards of health have fiscal oversight for health departments. They identify and approve the budget, they determine fees, they decide what grants to go after. So it's going to be an interesting time as this new model comes into play with the city of Milwaukee, because again, this is quite a paradigm shift of practice for us, because this is, up until this point, has been 100% controlled by the Common Council. Now, our first branch is medical services, and in medical services is two divisions. Clinical services, which includes the sexual and reproductive health program, the breast and cervical cancer program, and communicable infectious disease programs, and our public health laboratory, which has several sections. I'm very familiar with clinical services because when I was the director of disease control and environmental health, the disease control portion encumbered some of these programs. So what kind of things does clinical services do? Well, they provide services, sexual and reproductive health services at our clinics. Right now we provide those services at our clinic health centers. We do STI testing and treatment. We do outreach to people who have confirmed cases of syphilis and HIV to make sure that they have proper treatment, and we track down their partners. We do follow up with persons who have confirmed cases of TB. We want to make sure that they are properly treated, that their contacts are tested, and if they're show signs of latent tuberculosis, that they get post-exposure prophylaxis so they don't develop TB. We use our public health powers. TB is one of the few places that we will go to court and get court orders to mandate treatment, to mandate isolation or quarantine orders. In clinical services, this is also where we do our communicable disease investigations. We do things, we investigate diseases like your enteric illnesses, salmonella, shigella, your kind of foodborne illnesses. We also investigate your vaccine preventable diseases, measles, mumps, whooping cough. Why do we do this? What we're trying to do is, in our ultimate goal in this division, is to increase childhood immunization rates, whether it's at that primary series level in children 24 months of age, or later on when they get into school. What we're trying to do with our sexual reproductive health program is to decrease the rate of sexually transmitted infections. And again, our goal of our breast and cervical cancer program is to decrease the rate of breast and cervical cancer. Here's an example of some of the things that we put out and some of the things that we work on. Every month, if you're interested, on our website, you can find a report of the number of confirmed cases of communicable disease in Milwaukee County. It's called our ServNet report, Surveillance Network, ServNet. County Hagy. And you can find, and we also provide this year's numbers and compare it to the numbers last year. If we have an outbreak going on, we'll do like a press release. This one is actually from a year ago when we were seeing an increase of poisoning cases related to synthetic cannabinoids, when they had issues with radificum being in the synthetic marijuana, so basically rat poisoning, which was causing severe bleeding. We'll see like sporadic cases of vaccine preventable diseases like mumps. We'll do some messaging around that. We typically see that in college age students. You would think that at this day and age, vaccine preventable diseases would not be an issue, but you know, the United States is in jeopardy of losing its measles-free status and being designated as an endemic country because of poor vaccination rates for measles. Because there's been several states that have had these ongoing outbreaks. It doesn't take that many kids clustered together to propagate an outbreak. Measles has the opportunity to find that group of kids that aren't vaccinated and just keep going. The issue is, in my experience, I started off in infectious diseases, and I can tell you, by the time you get that first case of measles reported, it's never the first case. It's always the second, third, fourth, because that person, the first case was missed. The second case maybe got caught, but that person had been in that emergency room or to the doctor 2 or 3 times, and they kept going back until they figured it out. So once measles really started getting going, we did a lot of outreach to pediatricians' offices, to children's hospitals to say, do you have a plan? When that parent calls you on the phone to say, hello, I think my child may have measles. How are you going to test them? Because measles is airborne. You have to figure out how to get that child in without exposing everybody else in the building. And if that child's been in there, then you also have to figure out, if you didn't do it properly, who was in there at the same time and up to an hour after, and figure out everybody's vaccination status. And if you ever have to do that type of outbreak investigation, it becomes hundreds, if not thousands of people very quickly.
I should just make a note that as of yesterday, a news article came out saying that there was a child that had measles that went to Disneyland. And this was just yesterday.
And that is it. It's always like at these like theme parks or the most social person ever. It's never like the shut-in at home. They've been everywhere. Or it's that very like jubilant, like talks to everybody, college student that went out to this party and that party, talked to the whole world. And they're like, and then you have to just start making the lists. And then if it's a school-age child and there's people in their classrooms that aren't properly vaccinated, that child, if it's past the point where we can immunize them, where they could, the first period of where they could develop symptoms, they have to be excluded for 2 incubation periods. That's a long time to keep that kid out of school. And if there's continued transmission, then that kid continues to be excluded.
So the child with the measles is excluded, or the
child
that's not properly?
The child that's not vaccinated. The kid with the measles can go back as soon as they're not infectious. But if that kid that was not vaccinated, and they continue to not want to vaccinate that child, they have to remain excluded. And that can be a very long time. And you end up having a very emotional conversation with those parents about risks versus benefits, personal rights versus community needs.
What are the public school policies in Milwaukee right now? What exemptions do they allow for vaccines? Can anyone refuse to vaccinate, or is it just like religious and medical?
You can get a personal conviction waiver. So right now it is allowed, but what we all say is, 1, vaccines are safe, and 2, you run that risk of, if there's an outbreak, having your child excluded. It's one of the places where Milwaukee is not having as high of rates, where you see more personal conviction waivers are in more of the wealthy, affluent suburbs. So we tend to not see those personal conviction waivers. Now, Milwaukee has some issues with immunization rates. Our kids start late and finish late, but they get there. We don't see that as being an issue. We have access to care issues, which tend to slow down the process, but they do get there.
So, like when I was, when I was in elementary school years ago, they used to do immunizations in the schools. Like you get immunized in the school, like they'd have it in the auditorium and combine with their little shots. You guys don't do that anymore, do you?
We don't.
No.
That has to do with cutbacks on funding. So the only people we can immunize are kids that are Medicaid eligible because of reductions in the Vaccines for Children's program funding. So if you have private insurance, we can't vaccinate you. We'll go into, again, because the vast majority of kids in the MPS system are going to be at Medicaid eligible, if we identify a high-need school, we'll obtain consents and go in and do immunizations. We typically do that when they roll out new immunization requirements, because then there are so many kids behind. They are looking at new immunization requirements, I believe around meningococcal, and I think there was something else that they were considering, but that's still being debated in committee. So if they do go forward on something like that, then absolutely we'll go back and do something like that.
Just thinking, that would be the perfect opportunity to get these kids vaccinated because
It is,
like,
it
rid
is.
of them doing regular visits to their primary care providers.
We did that absolutely when they rolled out the chickenpox requirement. We absolutely went in there and did that because it was just more than private health care could handle, because all of a sudden there were thousands of kids that now were behind and did not meet this requirement. And the way the school immunization law states is if you're not up to date by the 25th school day, your kid needs to be excluded for 5 days. That's just the way the immunization law, So
Just 5 days, whether or not they have a vaccination after that?
that's the rule. You could do it longer, but the minimum is 5 days. So that's all MPS does. Because again, you have to weigh the need to comply with the law with the need to get that kid educated. And again, there's other social needs. Again, if you're excluding the kid from school, are they getting their other needs met, like a nutritious lunch? So they do the minimum, the 5 days. But usually it's that first day. All you need is the 1 day, because that's enough. They want to send that kid back to school. What do you mean my kid can't go to school? Okay, we're going to get this taken care of. So it's a very effective tactic. Unless you have schools that skirt that requirement and say, hey, your kid's going to be excluded, just sign this waiver and then you can be here. Well, then that's totally missing the point. The point is to get that kid up to date. And there's been a lot of debate policy-wise of whether or not personal conviction waivers should be allowed. And that's an ongoing policy discussion where there are states that have considered and removed that personal conviction allowance because of these ongoing outbreaks. Another challenge or opportunity for improvement for the city of Milwaukee is our sexually transmitted infection rates. So if I had to ask you how we rank as a metropolitan statistical area.
Very high. Are we like 3 or something?
Aren't we like the syphilis capital of the
Yeah.
nation?
Not syphilis, we do well in syphilis.
Gonorrhea.
Gonorrhea and chlamydia, not so well. So, it changes from year to year, but we're typically in the top 5 for chlamydia and the top 5 for gonorrhea. And we have been for as long as I can remember. And They don't change very much. It's the same few. So we can go back to the other one, you know. From year to year, it shuffles up and shuffles down a little bit, but not radically different. Syphilis impacts different segments of the population, where chlamydia and gonorrhea, as we go forward. Chlamydia impacts females. It impacts, again, younger females. Sorry about that. Same thing with gonorrhea. You see young females and males in the younger age groups. You see a disproportionate impact of people of color. Again, same with gonorrhea. Disproportionate impact of people of color. Syphilis, we are seeing a resurgence of syphilis. This is part of a national trend. As public health dollars have gone down, syphilis rates have gone up nationwide. Again, unlike other STDs, syphilis is primarily an infection of males, older males. However, we are seeing that kind of change. So again, primarily impacting people of color. What we are starting to see, which is concerning, is the number of cases of syphilis creep down into lower age ranges. And the reason that's concerning is that then raises the risk of congenital syphilis. We've had now a couple of cases over the past few years of congenital syphilis, and that's considered a sentinel event. That is a significant failing on the healthcare system. That means we didn't get that woman the proper prenatal care, and that baby is at high risk of significant complications. HIV, our rates are not, again, we're not considered, we have significant rates, but we are not one of the high incident areas of the country. We do disproportionately contribute to the rates of the state. So the vast majority of the cases in the state of Wisconsin come out of Milwaukee. Again, the rates have been pretty consistent over, the number of cases diagnosed have been pretty consistent over the last 10 years. You can see gender and age at diagnosis, just like syphilis, predominantly male. Men who have sex with men are by far more likely to be impacted than any other group. By far, men who have sex with men of color. Living in poverty, no matter which disease it is, chlamydia, gonorrhea, syphilis. If you look at those zip codes, the zip codes with the highest infant mortality rate, the zip codes with the highest rates of lead are the same zip codes with the highest rates of STI. So those social determinants of health. Poverty. Poverty is a big factor in these diseases. Those high-risk behaviors, trading sex for a place to stay, having unstable living environments, trading sex for money, all impact these diseases. As you can see, the rates of sexually transmitted infections in the city of Milwaukee versus Milwaukee County versus the state and nation, there's a very stark contrast. Several magnitudes of difference between what we experience in the city versus what we experience in the state. So what are we trying to do about this? Well, right now, we've brought a group of partners. Remember I talked about earlier where public health is a team sport. We are and have been working on an STI strategic plan, looking at what assets do we have out there in the community to begin to tackle this, because, you know, the definition of insanity is to do the same things over and over again and expect a different result. So for 10 years or better, we've been super high. So what can we do differently? So we brought our partners together and said, we have got to do something differently, or we're going to continue to have some of the highest rates of STIs in the nation. So we've sat them down and say, look at what can we do? And over the past year and a half, we've systematically did key informant interviews. We've talked with both people in the scientific community, and we've talked with youth who drive those numbers, and say, what can we do to change your behavior? What can we do to make you hear us? So that way we can get you into care. What can we do to stop the spread of disease? So the hope is that eventually we can take all of this knowledge and come up with a systematic plan to address the STI issue in the city of Milwaukee. And the plan, the strategic plan, is kind of the genesis of a series of unfortunate events. About 2 years ago, we had a rather large cluster investigation. And we presented on that cluster investigation at a community meeting. And that cluster investigation was shared with the media. And it wasn't portrayed very positively. So, when you talk about STIs, you have to consider a couple of things. A social network investigation is just that. It's talking with everybody who happens to know people and saying, hey, you know somebody. Do you know somebody else who could benefit from being tested or talked to about HIV or syphilis? And connecting them all together and seeing how many of those actually end up having syphilis or HIV. That doesn't mean they actually slept together. It just means they know each other. They are friends or acquaintances. And when you create a social network diagram, that just basically shows how these people are connected together. It doesn't make conclusions about how you may have gotten the disease. It just says you know each other. However, when you put it all together and indicate who may have had disease, and then somebody puts that together and says, holy crap, look at all these people with HIV and syphilis who happen to know each other, you have to control that message. Because otherwise what makes the front page of the paper is 125 cases of blah, blah, blah. Syphilis, HIV, or a combination thereof. The headline almost was 125 cases of HIV and MPS. It took a lot of talking people down off the edge to say, that is not what we have. These cases are not all new, they're not all old, and this is what we really have. So take a breath. They're only a small number of these kids actually attend an MPS school.
You know what's funny is that I remember this.
Yeah.
And I remember hearing, like, oh my God, there's like 100-something kids all sharing HIV with each other. That's what I heard.
Right,
So
and
I was like, oh my God. I live right next to a high school. I'm like, oh, these kids.
and no matter what you do, there's no putting that genie back into the bottle. No matter how many times you explain it, they only hear that first way that was explained wrong. So what it really was 76 of these 126 people who actually know each other. They didn't actually all sleep together. They just 127 people who know each other tested positive for HIV or syphilis. Only 19 had syphilis, 24 had syphilis and HIV, and 33 of these had tested positive for HIV. That means some point in their life for HIV. That doesn't mean they were even new HIVs. This could have been years ago. This was just identifying how in this one social group there was a great deal of high risk behavior. So, messaging in public health is very important so that people understand very complex issues. The plus side of this is the Common Council had heard us present on communicable disease. They'd heard us present on this very report 2 months before and had not paid it any attention. When this article came out, all of a sudden, they were freaked out. Oh my God, we have an STI problem. All of a sudden, it's like, what can we do to help you? And all of these community partners, there was this huge joint press conference with probably 20 to 30 partners who were willing to rally to say, we have an issue. And what was typically a turf war over, I want to do it this way, I want to do it that way, became a unifying time where we could, for once, create that synergy for collective impact. It created the spark for the strategic plan. So that way we could find that common ground, find that need, that driving factor to have us all come together, to work together, because nobody wanted to be the reason why we couldn't tackle this issue. So every cloud has its silver lining. What we do, one of the kind of unique things about public health and public health sexually transmitted clinic services is most of our services are provided directly by public health nurses. So if you're looking for a challenging career, come join our STI program where you can practice very independently. We have nurses who basically, with a BSN, they provide, they do testing and treatment of STIs all day long. You have a, yay, go us. And we're going to be expanding our services to do more family planning under, we'll be posting here very shortly for 2 advanced practice nurse practitioners. So that way we can start offering more comprehensive choices of birth control. So oral contraceptives, we'll do PAPs, breast exams, mammography, all that kind of stuff. So public health nurses have a great more deal of latitude in their practice. They practice under medical orders. So it's a very good way to use your critical judgment. Another example of the great services we provide is through our Well Women's program. It's really kind of a good safety net program. We have women who come in there. We serve about 1,000 clients a year. One example, again, you'll see a lot of Janes in our herd. All names have been changed for the sake of the presentation. So one example, we had a woman named, well, we'll call her Jane, who was looking for some help with her diabetes screening. We were able to screen her, found out she had breast cancer, and within a matter of weeks get her connected with care. This year we've already diagnosed 5 women with breast cancer. So that's above what we typically do in a year, but for women, especially undocumented women, they don't have any other place to go. We feel that need. Moving on to our public health laboratory. They provide most of the testing to support our clinical services division. They also support our environmental health, our various environmental health divisions. So they do all of our STI testing. They provide all our lead testing, and they also do some various research projects. One of their newest programs that they're very proud of is they're offering commercial garden testing for soil. And their objectives kind of go around that. One of the great things that we can do compared to other providers, we have technology over at our Keenan Health Center that allows us when a patient comes in to be tested for HIV, by the time they leave the clinic that day, they know their status. So that's a great program. We're also part of SURGE, strengthening the U.S. response to resistant gonorrhea. Because of the amount of STDs, there's a great concern about growing resistance. So we do, everybody who comes into our clinic, they obtain cultures and they determine resistant patterns. And if they have a resistant pattern, a disease intervention specialist does an in-depth interview with that person to try to identify what additional risk factors exist there to determine why this person has these additional antibiotic risk patterns. So that way we can better determine what's causing the antibiotic resistance to emerge. Another great thing that we do as a health department is we try to partner with other organizations to bring STI testing where it may be needed. We did STI testing this last summer at Pride Fest. We want to try to get out more into schools and other venues where it might be well received. Now, on to our next branch, community health. In community health, there's two divisions, maternal and child health. In there is our intensive home visiting programs, also like our WIC program and our violence prevention division. There we have, they have numerous initiatives, our Commission on Domestic Violence, safe visitation. I have to say this is probably the area of the health department that I know the least well. I'll do the best that I can. So the idea, the main goal of maternal child health is to assure healthy birth outcomes. They do that through intensive home visiting. The idea is that if you provide a new mother with support and get them the support that they need, that infant is going to come into the world in a much better place. Another way they do that is through the WIC program. You provide nutrition support, counseling, healthy food. Then they also do counseling around breastfeeding. They have a farmer's market. Again, trying to make sure that parents understand what nutrition they need when they're expecting and what nutrition their child needs. We've had this program for a very long time around safe sleep. We've seen increasing rates of infant mortality, and some of that, a good bit of, probably about half of that, is due to things that have nothing to do with the safe sleep environment, things like prematurity. But there are things we can control, like the safe sleep environment, and to do that we offer pack and plays. So we provide education about safe ways that parents, the safe sleep environment, and we provide them that pack and play. And within maternal child health is our community health access program. What that does is help people sign up for Badger Care, so Medicaid. if you need access to Medicare, we'll direct you. Food share, child care benefits, any state-run benefit program, they are going to help you navigate and get signed up for. And it's not just the new signups. What they want to do also is make sure if you've gotten onto these programs that you stay on these programs. One of the things that we've seen is that parents who are on Medicaid, we're seeing parents cycle on and cycle off. And that is concerning because then they have gaps in care, and when it they realize it's an issue is when they need the insurance. So we're trying to be more proactive to make sure, hey, do you have insurance? Can we help you stay on the insurance? We even do marketplace signups for those who don't qualify. So here's another success story. We'll take all comers. You don't have to be a new mom to be enrolled in our intensive home visiting program. You just have to have a significant need. We worked with this refugee mom who had 8 children. She didn't speak any English. Her husband, while she was pregnant, had a stroke and ended up having to move back with other family members to be taken care of. She had a referral with CPS and was basically living on W-2. Her home was at risk of having the electricity shut off. After she got enrolled into our intensive home visiting program, they were able to help her navigate and get resolve her CPS involvement, get her onto a payment program, and get her, there's programs that can assist you, energy assistance. They were able to get her working with a better social worker, and she was able to deliver a healthy baby. So that's really what we care about.
In this instances like this, do you guys do interpreters like an in-person interpreter, or do you do like video interpreter?
We have a couple of options for interpreters. It just depends upon the length of the conversation that you're going to have. We have an in-person interpreter service that can go out with us. We also use the language line. Depending upon how unique the language is the likelihood we're going to end up with a language line, because there's not going to be somebody with our contract interpreter service who can go out with us. You can imagine that it takes a very long time to use the phone and pass it back and forth for an interpreter. We'll use family members if they're there, if we feel like they're reasonably competent in it. But the preferred method is, if, again, for a home visit, is to have our contractor assign somebody. But there are some dialects when we have refugee families in that we have no choice, that we're going to have to get somebody from the language line, and sometimes they even truly struggle. And we've actually sometimes had to use an interpreter to somebody else because of the interesting dialects. So you find a way. You do the best that you can. Now, violence prevention is one of kind of the newest emerging areas of the health department, kind of changing that idea that violence prevention is a police issue and thinking violence as a public health issue. So the Commission on Violence and Domestic Violence and Sexual Assault is a group of community-based agencies that come together and really try to look at what are the driving factors around that in our community. Recast looks at trauma-informed care and ensuring trauma-informed training. Our newest program is 414 Life, and that's kind of the violence interrupter model, and that's modeling after the city of Oakland, where you have people who are very familiar with the community, what's going on to the community, be able to go out and outreach. And when they find out about issues, they try to diffuse things before they bubble up and result in retaliation or violence occurring. Right now, we have violence measures as outcome measures, but we want to do a bit better with that. And for me, trying to wrap my brain around how this program works, maybe a story that will do it a bit more justice. So for example, Jordan, not his real name, had some involvement with the police and was part of the violence interrupter program. By working with our staff, Jordan was identified as having a significant medical issue, which he was feeling like he couldn't go back to the hospital for, because he was concerned that if he went back to the hospital, he'd be arrested. But he had been in significant pain for a week and had not had a bowel movement. Because of our violence interrupter program, we were able to pave the way, assure that Jordan would not be arrested because he was not in any legal trouble, but because of the violence that he had seen, he was just concerned about that. So again, we were able to assure him that that wouldn't happen. We were able to work with the hospital to make sure that they were aware of his concerns, and he was able to get in and get seen for his bowel obstruction, which could have killed him.
How did you get a hold of this person? Like, did they call you and like, hey?
So how we do find out about these people is like when there's a significant event, like a shooting. We get referrals for people who were tangential to that event, who were exposed, could have seen it. So basically, they suffered the trauma of being exposed to this event. And then we basically case manage them. How are you doing? Can we provide you some counseling? What's going on in your life? So the idea is if you're exposed to a shooting, you're more likely to then be a victim yourself or shoot someone yourself.
So if you're exposed to a shooting, aren't you legally, like, the police can pull you in for?
So this is where is the kind of the, so this person was no longer a person of interest.
Not even if they're not of interest, if they witness something.
Right, they could.
Okay.
So that's where there's always this concern. They're like, well, is somebody going to be wanting to shake me down, or are they going to pull me in and put me on a hold? And there's all this anxiety around these issues, both with the police and then the retaliation from the community.
So do you work with the police departments and say, hey, we have this person, don't shake them down, don't take them in, we want to get them help? I mean, how does that work, I guess? Sorry.
My understanding is that they navigate that walk. Again, the area I'm least familiar with is that they work those relationships at the district level. They understand what their interest is and is not in individuals and try to broker those relationships. So the idea is to de-escalate that. So they get, a lot of their referrals are from the police. They know that we're working with these people, that we're trying to make sure that they don't, again, become victims themselves or offenders themselves. So we have to have some understanding of what the investigation is, but at the same time we cannot divulge the status of the investigation. It's a very
Muddy water.
Yes, precarious relationship. I thought there was any other questions on this one? It's a very interesting model, and Oakland had a great deal of success by doing this, walking this tightrope of trying to help people out when they're in these extreme high stress situations. Environmental health, back to a safe space for me. So in the environmental health branch, there's 3 divisions. Home environmental health, which is essentially our lead programs. Emergency preparedness and our environmental health catch-all for those things that don't fit into other areas of environmental health. And our consumer environmental health, which is our regulatory programs, restaurant inspections, weights and measures, and tattoo and body piercing. So here are kind of things that we work on. We do a lot of, in home environmental health, this is where we do investigations of children with elevated blood lead or anything above 5 micrograms per deciliter. So our interventions vary based upon the level in the blood. Our intervention can vary from just a letter notifying the parent, hey, your child has an elevated level of lead, to a full on, nurse case manager assigned to make sure that kid gets follow-up testing, gets a developmental screen, gets referrals to Head Start if they need them, and an environmental assessment, and if they find lead in the home, we could end up abating the lead hazards. We also do a lot of work around lead in water. Each year, about 25,000 children get tested for lead. We as the health department test very few children. Most of the testing is done through our WIC program. As the home environmental health program, again, a few hundred. The city of Milwaukee has high rates of lead poisoning. The reason for that is not lead laterals. If you come away with one thing tonight, the reason for lead poisoning in the city of Milwaukee is high rates of houses built before 1940 and high rates of poverty, not lead laterals. There are multiple sources of lead paint, lead in water, lead in soil. The main sources of lead poisoning is lead dust. Lead exposure from lead in water is of particular concern for bottle-fed infants because that is their main source of nutrition. Our lead poisoning levels have remained kind of consistent over the last few years. We are trying to become more aggressive at our lead abatement activities to hopefully restart our downward trends. So as I talked about, our intervention schedules depend upon the level in the blood. There is no safe level of lead in the blood, but because of the magnitude, about 2,200 kids per year in the city of Milwaukee test at 5 micrograms per deciliter or more. We have to triage, so we cannot possibly do the same level of follow-up for them all. There's just too many. So we start with the most aggressive follow-up with kids above 20, or if they have repeat values above 15 or more. And those are venous tests, not capillary. The problem with capillary tests is there is a propensity for false positives. How the system works is the healthcare providers perform the tests. Every test that gets done is required, positive or negative, to be reported to the local health department. We enter this into our surveillance system. If it meets our criteria for an assigned case manager and field follow-up, we sign that to a staff and we do follow-up. We try to reach out to the family, and that's when a lead inspection risk assessment is done. At that time, if lead hazards are found, we'll do a full, it's called a LIRA, Lead Inspection Risk Assessment Report. We'll issue legal orders that require the property owner to fix those lead hazards. They have to, if there's lead found, they have to get a permit, and you have to be specially licensed contractor to do that work. And anytime lead is being abated, our staff are out there each day that contractor is on site to make sure they have proper protection in place. Just some kind of visuals. So lead and paint has a very distinct look. You can see the chipping and cracking paint. It has that kind of alligator look. So if you look at these windows, the window on the, let's see if I can do my left and my right. Left had a level, so the definition of lead paint is 1 milligram per centimeter squared. The window on the left had a level of 9, and the window on the right had a level of 17.4. So the issue that happens is as the windows go up and down, it creates dust, and then in the summer you open that up, and the wind comes in, and it makes a fine particular mist, and then the child either can breathe that in, or lead paint is very sweet. So little kids will pick up that paint and they will eat it. And you'll get a kid who gets like these super high levels, like they have like a level of like 100. And they'll x-ray the kid's stomach and they'll see the chips. And those are the kids who have to actually undergo chelation, and they get hospitalized in children's until those lead levels come down. As lead inspectors, we get creative. We don't want to leave hazards in the house, so it takes a while to get a licensed contractor in. You become an expert at duct tape. So when we found this chipping paint, and the kid is sitting there peeling it off and eating it, you fix the hole. You patch it with duct tape. So when we create our lead-safe home kits, they come with sweepers to sweep up the dust, and they come with your very own roll of duct tape. But if the lead risk assessor is there, they will do a nice patch job for you. A lot of places that you see lead paint also is in door jams, because anytime you have friction, it creates dust. You breathe again. That's where the hazard becomes. And another great place to use duct tape. So old homes, they've been painted, and they've been painted over and over and over again. If you have a home built before 1940, there's a high chance that it has lead-based paint. Before 1978, there's a possibility. If it's newer than that, odds are there's no lead paint there. Again, unless you go to the antique store, you buy that vintage painted piece, and you put it in your brand new home. Then you brought in the lead through that vintage painted piece. There's that chipping and painting look. Latex paint does not peel like that. You see the big sheets? That is lead paint. Chunks of it. On stairs, because they painted concrete, which you would think, why would you be concerned about lead paint on floor? Well, in this situation, it had a reading of about 10. Again, the alligator cracking. Soil. The issue isn't the soil, it's the lead paint that has chipped off the outside and fallen into the soil. The threshold for lead soil being contaminated is around 500. This soil is so high, and you see the kid's troy there, it's going to have to be dug up, removed, and new soil put in. And kids are out there playing in it every day. Another aspect of home environmental health is healthy homes. So that's taking a more global perspective of the risks in the home. Are there safety and trip hazards? Are there mold hazards? There's been a strong correlation that, if you look in a home and you have these kids that keep going back to the emergency room for asthma, if you start looking around, you're going to find these asthma triggers. So as part of our lead program, we have the supplemental funding that we can work on those hazards. So we can rip out that moldy garbage. We can look at the harborage of insects and see if those things are also contributing to problems within the home. Water quality. There's been a lot of hype around lead laterals and their contribution to lead poisoning. And any home that we go into that has an elevated blood lead, we offer to do lead testing of the water, and we provide a lead filter. Other places we do water testing for lead is in charter schools, and we do testing anytime there's a lead lateral placement program for childcare facilities. We do testing after the lead laterals are replaced to make sure the water comes. When you replace a lead lateral, it's documented that the lead levels spike after because you're disturbing the lines. So we test afterwards to make sure it goes back to a normal level so that they can come off of bottled water.
What's a lead lateral?
Okay, so back when the city was built, the pipes underneath the ground were made out of lead. So what they're doing is getting rid of those because of the concern that as the pipes age, it erodes and then lead chips fall off. So as the pipes break, they replace them, or with these targeted areas, because it's going to cost billions of dollars, they do that. So the lead lateral is from the curb stop to the home. But on the other side is the homeowner's part, so they have to pay for that part too. So kind of a success story is we work with a couple of community partners to try to get into homes. When we can't get a lot of success, we'll reach out to our partners like SDC or 16th Street to see maybe if somebody other than the government knocking on their door will kind of pave the way to say, hey, will you let us in to try to abate the home? And here's just one example of a home that we found significant lead and chipping paint, and then what it looked like after we abated. All right, consumer environmental health. Consumer environmental health, just like it's implied in its name, is focused on regulatory programs aimed at protecting consumers. So we regulate body art facilities to make sure that you don't get infections when you go get your tattoo and body piercings. We regulate food establishments, whether or not they're grocery stores or restaurants, weights and measures. So if you go to your gas pumps and you see those stickers on the City of Milwaukee, we test those to make sure that if you pump out a gallon of gas, it is a gallon of gas. We inspect school food programs, and we're also working on healthy food access. So in a given year, we'll do about 7,000 food inspections, about 1,000 weights and measures inspection, about 200 body art inspections. And what we're looking for are these critical violations for food inspections. What a critical violation is a violation that has a high likelihood of contributing towards a foodborne illness outbreak. And what people typically complain about, like garbage in the bathroom, those aren't the things that contribute to a foodborne illness outbreak. It's about the things that you can't see. It's about making sure the refrigerator is at a proper temperature. It's making sure that in that refrigerator, they don't have meat stored over the vegetables that they're going to serve raw. It's about making sure that that cook is washing their hands, and that if they're creating like soups and they're holding out soups, that they're being held at the proper temperature. So we appreciate all those calls about, I think this place, they're not wiping down the tables. But really, at the end of the day, that's not probably going to make as much difference as how well they're handling that food in the back. One of the things that the city of Milwaukee has done, and I'm not sure if you've seen that, is they've become the first local health department in the state of Wisconsin to implement a food establishment grading system. And starting with this year, the posting of the grades is now mandatory. So if you go out to eat in the city of Milwaukee, you should see that grade posted in the window. And the reason why we were able to implement that system against the will of the legislature is the fact that those systems have been scientifically proven to reduce critical violations. And we're actually partnered with a couple of researchers, nationally renowned researchers, to provide the data and show that at pre and post implementation of our system that the number of CDC risk factor violations will go down. So basically backing up what we're doing and showing that it works. Because unlike other health outcomes, one of the places we do shine is in our food inspection program. Again, weights and measures. We do, if you go into a deli, we do those scales. So again, if you get a pound of ham, we know it's a pound of ham because we've taken weights in there to make sure that it is properly, you get what you pay for. Gas pumps, we don't do parking meters, you're on your own there. What else do we do? We do taxis, so we do those meters. So we make sure that a mile is a mile, the time is the proper time. We do like the big recycling scales, those type of things. Body art establishments will go in and make sure that they use the proper equipment. So if they're using disposable stuff, that their areas are clean, that they have the proper, if they're doing any kind of body art, that they have those proper equipment. So if they have an autoclave if they need one, or if they're using all disposables, so that way you know that you're not going to get an infection if you get those type of services in the city of Milwaukee. We've really done a lot of work with our food establishment operators. It's always for a regulatory program, we like to take the approach to educate before we regulate, because we do have the ability to issue citations and fees, and those can escalate quite rapidly. So we always try to provide as many opportunities as possible to prevent a problem before it happens. So we do education sessions. Food trucks are a challenging area.
So don't eat from them?
No. There are some fabulous food trucks. And the vast majority of complaints from food trucks have nothing to do with food safety. It has everything to do with parking. I would say 95% of food truck complaints has everything to do with parking, and well, probably 90% with parking, 5% with illegally the generators or power issues, and then the other 5% with like food handling issues. But it's that others. It's that other stuff. I don't want them there, or so-and-so's taco truck is parked outside somebody's brick and mortar restaurant. So just trying to navigate all of those complex relationships make them much more difficult. And then you never know where you're going to find them. So then you have to hunt them down. So trying to create those relationships so that they kind of understand the rules of the road and can kind of be a more conscientious purveyor, so that they don't get local businesses riled up. So they don't call their alderman, who then call us, which kind of causes this cascade of issues. So anytime we can really talk with them and connect with them and say, here's how you can operate in a way that you can do it safely and in a way that is going to meld with the community, is a win-win for everybody involved. But my advice to you is look for that grade. It will tell you how they're doing. And all of our food inspections are online. So if you want to know how that establishment is doing, look up their inspection history. It will tell you exactly how well they're doing. If you see a violation, a critical violation, over and over and over again, that is not a good thing. So that's saying that that's how they operate every day. So you can bet that's how they're operating when you go to eat there. So if it says they're not washing their hands, well then they're probably not washing. If the last 3 times we were there they weren't washing their hands, they're probably not washing their hands today. If they're not hot holding food right the last 3 times we're there, they're probably not hot holding food right when we're here today. Again, these inspections are random, so if the last 3 times we were there they weren't doing it, they're, again, you gotta play the odds. So look it up, be informed, make an informed decision. That's the benefit about putting it online. Any place in the city of Milwaukee, you can get it from our website, check it out. You can see how they're doing. The last area, kind of the catch-all for environmental programs that don't fit in, that aren't lead and aren't consumer environmental health, fall into emergency preparedness environmental health. So this is climate change, this is nuisance complaints, this is our rabies calls, and they also do our emergency preparedness response planning. One of the most visible programs we have in this division is our beach monitoring. So from May until September, every weekday we collect samples at McKinley, Bradford, and South Shore beaches. We analyze those for E. coli and we make postings about the beach water quality. That's posted to our website and placarded at the beaches. We do water samples, drinking water quality samples on the Summerfest grounds. And then we also do some environmental evaluation for monitoring for mosquitoes, as those are becoming more of a concern as a disease vector, not only for West Nile, but things like Eastern equine. So we'd like to know what mosquitoes are around and how prolific they are.
So the Eastern equine that you talk of, is that the one that's causing the issue over in Michigan with the encephalitis?
That is.
Okay, just checking.
And mosquitoes don't like to stay in one place. So it's going to be interesting to watch to see how that becomes more of an issue. You know, it was for a while the big issue was Zika and whether or not that would spread. Mosquito or vector-borne diseases has, you know, with the issue of climate change, has become more of a concern, both mosquitoes and tick-borne diseases, and how that's rapidly evolving.
Do you guys focus for like mosquitoes, mosquito-borne illnesses? Do you guys focus mainly on like how I don't get like mosquito bites, or do you focus on how to get rid of the mosquitoes? Does that make sense?
Yes. We focus on trying to do health education. There is not enough larvicide in the world to go through and put it in the catch basins and all the standing water in the city of Milwaukee to mitigate that issue. So the idea is to explain to you how to mitigate your risk when you're outside. So proper use of mosquito repellent, how to not breed mosquitoes yourself. We do have a limited amount of larviciding we do with those places where we're known to have. We have in the past. We haven't done larviciding in a couple of years because they're actually, we did a study a couple of years ago to see if it was even effective. So the reality is it takes very little water for mosquitoes to replicate, and then we just treat a few sources, so it's not going to really have that big of an impact on the number of cases the years that we've done it and not done it, for at least cases of West Nile, because it's already endemic in here. Now that might change should something like an Eastern equine come in and the dynamic of the concern of the disease change. At the end of the day, it's going to come down to you practicing good mosquito bite prevention measures. Things that you might not think that the health department gets involved in. One of the first things that I was involved in, we did a hotline for the fall explosion. So we got the calls for families who were looking for their loved ones after this event and had to triage and let them know where to go. Another big emergency response that we put together was for H1N1. It was one of the first times we actually did the biggest mass clinics that we ever run, where we put through thousands of people. We did those at schools. So when there is a big concern, flu has the ability to mutate, and during this particular year, there was concern about the virus being particularly infectious and impacting younger people. We had a plethora of cases here, and actually we published several articles based on the experience here in Milwaukee because we had the ability to test very quickly. And it was an interesting time. We, within emergency preparedness, try to make sure people are aware of and prepared for extreme weather. So whether it's extremely hot or extremely cold, we work on messaging with our media outlets. So to make sure that they put the message out there, and then we work with our partners to make sure that there are cooling places or warm places that are open in when these extreme weather events go on. And then kind of the more mundane or routine public health is responding to exposures or animal bites, this type of thing. So if you have a bat in your house, give us a call. Don't assume that it doesn't have rabies. We get several of these every year that do test positive. So we can facilitate that bat being tested by the Humane Society, and then we can help you navigate getting rabies post-exposure prophylaxis. It is a series of shots, but it's more desirable than any other outcome.
Do you get that if you weren't bit?
Well, the problem is a lot of times people find them in sleeping rooms and they're not sure of their status. They wake up in the middle of the night and they're like, oh, there's a bat.
You wouldn't know that biting you?
The saliva is the issue. And then there's usually the heroic story of how the bat is captured in a not so safe manner.
Oh,
With various unique equipment scavenged from different parts of the household. If they weren't exposed before, by the time they capture the bat, they are then. So call the health department before you attempt capture if we can give you some advice on how to do that safely. Usually one of the two occur. The last, the fourth branch within the health department, which is where I am currently housed, is policy, innovation, and engagement. And this is kind of the think tank for the department. Health strategy, that's our community health planning, data and evaluation, and health communications. what public health planning and policy really kind of focuses on is accreditation, community health assessment, doing our policy work, so whether or not it's trying to advocate for changes in our local municipal code or advocating for changes in state regulations. We work on performance management, quality improvement, strategic planning, so we help areas of the department, like whether or not it's our sexually transmitted infection program that's wanting to work on a strategic plan, or different programs, or the health department as a whole. One of the big pushes for public health in the last few years is to get health departments accredited, because there has been such variability in what a health department does. And accreditation basically brings with it national recognition that you meet a benchmark standard. What we also do within planning and policy is serve as a convener for community coalitions. One of our primary areas of emphasis of late has been substance abuse, so we've done a lot of work around naloxone, working on the city-county, I'm going to get this wrong, city-county cocaine and opioid task force plan, and making sure there's resources out there related to that. The other big area of policy and innovation is health communications, and they basically are the hub for creating all our health education and promotion materials. We do a lot of community health outreach events. We do our biggest event all year is our back to school health fair. We've been doing that for about 18 years. During our 2 events, we serve over 30 states, nearly 4,000 community members, and provide a number of direct services. I have a little video to see if it works. The community health fair is a way to get out into the community. And provide services where people are by combining it with a multitude of, kind of add some fun to it, like face painting and like drum corps and all that kind of stuff. You can attract people and get them to do the things that we want, which are immunizations and blood tests. by giving them things that they want, which are the fun things. So it's, we have, like I said, we have more than 100 different vendors at between the two events that offer a myriad of services that help get kids back to school. Because we know getting kids educated and getting a good education helps result in better health outcomes. So it might not seem like that's health, but if you take a social determinants of health approach, it's all health. A lot of things that health communication works on, anytime we have like a press release, they're the ones who kind of serve as our hub for working with the media. One of our most picked up pieces of late was the press release that we did with vaping. It reached 547 million news viewers, because we were one of the first health departments to come out to say, don't vape, it's not safe. And sometimes with public health, you can't always wait for somebody else. Somebody's got to be first. And we took a lot of flack for that. But if you look, it wasn't long after that states came out and said, hey, we're going to ban flavored vape products.
Who did you take flack from mostly? Did you say, I mean, obviously not, the manufacturers.
The manufacturers.
Okay.
We got a lot of pushback. You haven't proven this. Most of the cases are from, people using illegal substances in this. It's not us. It's not our fault. And we're like, hold on. If you look at the substances that are in here, they're known to cause lung disease. They're known to cause problems. And you're saying that these are safe. These are creating flavors that attract kids. And this has gotten totally out of hand. There's kids that are, the proliferation of these devices is creating a public health epidemic that we don't even understand yet, because there's no research to back it up. We're not going to know what problem we've created for another 10 or 20 years. And if we're seeing this type of lung disease now, it might not even take that long. So it's going to be interesting to see what the long-term health effects are of these devices, because we don't know. It's going to be a good policy discussion to see what happens. But if you do good public health, if you're willing to take a stand, you can get your message out there, and this is how you can use the media to amplify your message, because this cost us nothing. Not 1 cent, and we reached 547 million people to say, hey, don't vape. That's the Milwaukee Health Department. We have 4 divisions, an abundance of programs. We have numerous openings, so watch the city of Milwaukee. Come join us. We are rebuilding and re-envisioning ourselves. Any other questions about what I covered, things that I didn't cover?
So you have openings, are these like RNs, or are you?
We always need nurses.
Oh, that's future nurse practitioners. Do you use a lot of nurse practitioners?
We're hiring our first 2 nurse practitioners, because we are just now kind of expanding our services to embody a full family planning clinic. So in our SCI clinic, we had RNs just doing SCI testing, but as we expand out, and we're going to do PAPs, colposcopies, we're going to do oral contraceptives, we're adding 2 nurse practitioners, and if that goes well, who knows? The issue is that with politics, There is more than ever a humongous need for sexual and reproductive health care, family planning. It's unfortunate that the providing of reproductive health care is being so politicized. For those of you who aren't familiar, there is a strict gag rule around accepting Title X funds. So if you accept Title X funds, you cannot say the word abortion. You cannot make a referral to a clinic that provides abortion services. So,
If they do other,
doesn't matter. Doesn't matter. So then the number of providers that are accepting those funds is dwindling. So there are places where you can receive free family planning services. So that is really creating a need for those women of extremely low income. So the health department is trying to figure out, in an environment where we're trying to get away from direct service, is this now a place where we're going to need to step up and provide more direct service? Because we are the only clinic in town where you can get these type of services without having to pay any cost. And up to this point, our sexually transmitted infection, our reproductive health clinic has largely been male. So this is a complete paradigm shift for us about figuring out how we're going to fill this goal, especially if Planned Parenthood, which has been the biggest provider in the market, cannot weather the storm of reduced funding because they are no longer receiving Title X funds. So it's going to be a challenge. So these funds are now going to places that provide, or may end up going to places that provide little to no actual direct care. So stay tuned. There's a number of legal challenges to this, and we are waiting those out to see how we change our programming in response.
Do you do a lot of work with the homeless populations in Milwaukee at all?
A good number of our clients have housing stability issues. There's a great deal of transiency in the families that we serve, moving multiple times a year. There's great concern recently around the tent city and the rehousing of that group. So where we wouldn't have normally got involved because it's traditionally a county function around homelessness, we do work with and partner with a number of the agencies that serve the homeless population. We've partnered with the Bread of Healing Clinic to provide free flu shots and pneumonia shots. It is becoming more and more an issue. The city is looking at whether or not it can create some housing programs to address some of that, but we have not, as a health department, come up with specific programs yet. But I'm sure it's something that is going to become more apparent.
Do you guys do anything in like the mental health area?
So our foray into mental health so far has been opioids. It is one of the priority areas of our community health improvement plan, but because mental health is a county function, it kind of makes it a difficult area for us. We're trying to get more into like suicide prevention, but we don't do a lot right now. Any other questions?
A question. Is there a possibility that the county would ever consider offering just nursing students the ability to do some clinical practice at these health centers, nursing students, or graduate nursing students?
With the health department?
Well, we just wrote, Junine and I and Anne just wrote a grant to create a clinical program at the health department. And one of the first, and it's more gauged at undergraduate students, and they would be working within the lead program, but we could probably look at other placements at our other programs if you're talking about like clinical placements for like nurse practitioners. We absolutely could do it. Once we get our nurse practitioner done, small steps, but yes, absolutely. I think it would be, our new director of clinical services starts November 4th, and then I'll put her on it, and we can begin to look at that. I think it'd be a great opportunity for a nursing student to have an incredible immediate impact in the community. So we could get you up and at least doing a full SCI exam probably within a short period of time, and then we can move on from there. I mean, demand is not an issue. Finding the space, we'll have to find a room that will probably hold a put you in, but we can do it. Let me write that down before I forget. NP. And I think, and maybe, yeah.
I went to UWM for my undergrad, and they have like a huge population-based focus instead of like hospital-based. So one of my clinicals, I think it was my senior year, my first semester senior year, the first 8 weeks I spent at the health department, the Southside Health Department, and we went into they weren't like the highest risk new mom homes, but we took out the scales and weighed the babies and checked for lead, and the ones that didn't have a safe place, we filled out the paperwork to get the pack in place. And then the second half of the semester, we were actually at XDC over on, I don't remember which location we were at, but it was like during the time where they were signing up for the energy assistance, so they had like the huge long lines. And when people, they would grab their number, and then we would go and do cholesterol screening and blood pressure screening, and we would ensure they would not lose their spot in the line, like if their number was called. But then anybody like that was deemed high risk, our instructor would try and get them in with a clinic for follow-up.
That sounds like a great program.
11 years ago.
Yeah, I'm not sure that happens anymore.
I don't think UWM goes into it anymore. I think there were issues with safety going into homes, because I mean, looking back, it was me and another nursing student going into.
It was just you guys?
Like 2 of us, yeah.
You didn't have your instructor with you? Oh, no.
Like we would leave, you know, the address where we were going and contact information, and we were like out.
Yeah. Well, the way we're thinking about structuring this new program is that they wouldn't go out with their instructor, but they would go out with a lead risk assessor, so it wouldn't just be 2 students. So you would be with somebody from the health department, because there's no way to get people out otherwise, but it'd be a lot of phone follow-up to do health education on lead. And the idea would be that the undergraduate nursing student would call, do health education about lead, advise the parent about what to look for, see if they need, advise them when to get retested, and see if they'd be interested in having a lead risk assessor come out and do a full lead inspection risk assessment. And then if they came out, then the nurse could come out and do further health education, and maybe do, we can see maybe do an ages and stages assessment, or just further general lead education. Or they could go do the, show them how to do interim controls to keep their house lead safe until it can be abated. So that's what we're thinking, and we'll find out about that grant program November 1st. So we're super excited about the potential to do that. So that would have Alverno students at the City of Milwaukee Health Department starting February of this year.
And just Alverno students?
To start out, yes. Yeah, small steps. and then maybe do some internship programs. Anything else?